Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, the VP of Marketing here and your host today. Our topic is At What Cost? Diving into cost in value-based care. This will be presented by Dr. Dan Mingle, Executive Chairman and a founder here at Mingle Health. Before we get started, a few logistics for today. This session will be recorded. The slides and recording will be sent out by email later this week. You can also go ahead and download the slides from the GoToWebinar panel of the session right now if you'd like to download those and follow along. Before we get started, a quick introduction for those of you who may be new. Mingle Health, we seek to be your trusted partner in the transition to value-based healthcare. We help you improve what matters by helping you save time, improve outcomes and quality scores, and ultimately helping your bottom line in the practice of medicine. We're really excited about this series because increasingly cost plays a factor in all of the value-based programs, and you're navigating it constantly. So with that, I'm excited to introduce you to our presenter today. Dr. Dan Mingle, as I mentioned, is Executive Chairman here at Mingle Health. He's also a nationally recognized quality reporting expert with a background as a family physician in group academic practice experience. And he has many insights into what plagues our healthcare system. And that's led him here today to this topic, to this presentation, and to his lifelong mission of improving healthcare and this transition to value-based care. So with that, over to you, Dr. Mingle.
Thank you, Charles, and good afternoon or good morning, everyone, depending on where you're tuned in from. I am Dr. Mingle, and I also want to wish you a happy new year. This is, and in celebration of the new year, I'm excited to offer this new topic to our public webinars on cost. So our plans today talk about why I'm interested in cost now, talk about its multiple dimensions and values, some of the common terms you hear about cost and cost effectiveness and value, and then start to apply that cost-sensitive thinking to the value of your service, the profitability of your practice and healthcare system, and your success in the value incentive programs. This is preparatory for two more sessions. I really didn't think I could get it all into this one, and you'll understand that intimately, I think, when I bore you with the rest of this presentation. But my intent here is to set a foundation of language, terms. I may not be using them right, but I'm going to tell you how I'm using the terms so you can follow along with the rest. And then 2 weeks from now, we'll talk about the specifics of succeeding in MIPS and the Quality Payment Program, APMs. And then because cost is so integral to the it's so important to be able to profit in practice and have a financially rewarding practice. Some of the measures of cost affect both, and some of your decisions affect your profitability in your practice as well as the value that you deliver. We'll be doing a follow-up a month from now on the profitability of your practice. So I think as providers, we tend to share the triple aims, if I can borrow that term for a moment. Our intent is to provide a high-value healthcare to our patients. I think there's a few of us out there who aren't in the business for that, but most of us at least pretend to be there if we're not. And while keeping our practices rewarding, personally, professionally, and financially. And I think we don't often enough talk about it's good to keep our practices rewarding. And then again, we also need to excel in those value-based incentive programs. And I intentionally put them in these orders, at least it reflects, I think, to me, the relative importance of those three goals. And let's start with acknowledging and understanding the problem that exists today in the U.S. healthcare system. I think there's two faces to the healthcare system, and as I look at it, I realize that we are, in a lot of senses, a triumph of the market economy. The annual spending on healthcare is $4.1 trillion, and what industry wouldn't celebrate that kind of a flow of dollars? And healthcare employed 19.7 million people in 2014. I didn't find a more recent estimate of that, and as of 2014 was growing faster than any other sector, and I don't see that any reason to expect it's changed remarkably since then. At the same time, I see failures of that program. And I think in the United States, we suffer from perhaps the lowest value of healthcare in the developed world, and I'll review some numbers on that in a moment. And medical debt, according to the Kaiser Family Foundation, is striking, putting about 600,000 people into personal bankruptcy annually. From unexpected healthcare bills, and healthcare costs adding substantially to the price of every U.S. export and contributing to that imbalance of trade. So to put some numbers behind those statements, there's a couple slides I'm presenting from the Organization for Economic Cooperation and Development. This is an organization with 39 member countries, which you can read across the bottom of the screen, and this balances things or adjusts for the costs in the various countries, and looks at both the government contribution to healthcare expenses and the voluntary out-of-pocket expenses, and puts those together. And in this analysis, we come out head and shoulders above everyone else in the economically developed world, more than 2.5 times the average of all those countries, and head and shoulders above the second runner-up. Now, you might argue we get great health care in the United States, and so it's worth paying more. But the OECD also looks at quality from a lot of different perspectives. There isn't a clean roll-up like there is for cost, in which you can convert everything to dollars. But here on the left-hand side of the screen lists some of the ways that the World Health Care Organization looks at comparative quality by nation. I chose two of the tables or graphs to show you, and I think as you leaf through all of these, and I don't know why I jumped ahead there. There we go. As you leaf through all of these, you find that we're closer to the bottom of all these graphs than to the top, despite our highest expense in the world. So enough said there. And here, this final graph from the OECD takes 11 of the countries in the top half of the expense chart and compares their performance to their cost, which is really value, as we'll explore a little later in this discussion. And we stand out as being the highest care for the lowest value across that group. So I've gotten into arguments with people about this. I remember a time I was presenting out on the West Coast and shared dinner at the hotel bar with a judge who was in from the other side of the country attending a conference, and who was incensed when she learned what my profession was, that I was in business to try to improve the value of healthcare. She claimed that healthcare in the United States is the best anywhere, and I started to get a glimpse of her perspective, and have tried since to bring that to balance. And what I'm understanding is we are great at disease science. We export technology for the diagnosis of disease and the treatment of disease. And I think that rightly gives us some bragging rights about the quality that's available in the United States. But we don't really follow the science of distribution very well. We don't study it much, we don't practice it much, and we've got great problems with distribution. Particularly, we're hearing a lot about social determinants of health and how people in socially disadvantaged groups don't get the care that everyone else gets. And we have multiple sins of omission, multiple sins of commission, and illustrative of that is the NIH, through which most the federal budget for healthcare research flows, has about $43 billion annual budget in 2021, and most of its budget is spent on specific diseases in the diagnosis and treatment categories. AHRQ is the portion of the NIH funds which studies distribution science, and that gets about 1% of the total research budget in the United States. And I think that starts to help me understand why we have this disconnect, and realizing, well, we'll get to that in a couple of slides. See if I can. So I'm introducing here some data from the Dartmouth Atlas study. And if you don't know about the Dartmouth Atlas, I'll give a connection to it later in the deck. They've had about a 3-decade run, founded by Dr. Jack Wenberg, trying to understand and explain variations in costs of healthcare across the nation. And one of the perspectives, they look at it often from the hospital referral region perspective. There are 36 of those in the United States. The hospital service area perspective, about 5,000 of them, and primary care service areas about 6,000. It's a process of understanding for each zip code where the majority of people in that zip code get their primary care, thus the primary care service areas, where the the first level hospitalization, acute care, occurs. That's the 5,000 hospital service areas. And then the tertiary hospital that serves the region, at least the majority, where that flow goes. So then the 306 hospital referral regions. And yeah, you see that map here on the left-hand side. The color coding is for the cost of care per individual, Medicare cost per care for individual in that area, and this roughly shows you that distribution of the hospital service area, hospital referral regions. What we call that graph up in the upper right-hand corner is an onion graph. Every dot represents one of those 306 referral regions, and they're organized at that level at the cost of care per person for Medicare recipient per year. And you can see a fairly broad range from, and now this is $1995, and I'll 1995 analysis, which is getting pretty ancient, like me. But I'll give you some more insight on that in a moment. But it shows a high of about $8,000, nearly $8,500 per year which we enjoy in Miami, and closer to $3,000 per year at the bottom of the range enjoyed it in Minneapolis. So let's see, what's this? Yeah, the next one gets us into some more modern analysis of that. Of course, prices have gone up since 1995. And you'll see one of the problems in healthcare, again, is here in this graph. Consumer price index shows us an inflation of 1.6. So something for the cost of $1 in 1996 costs $1.60 in 2018. But in healthcare, a dollar of healthcare in in 1996 cost $2.18 in 2018. So we go back to that onion graph a moment and look at the numbers, project them forward, and going by this this healthcare specific consumer price index, we really predict on the average that we're pretty much right on target. Of course, that's how the whole thing is calculated, so that makes sense. We also see that we've tightened the range a little bit, so the high isn't quite so high. It would have, at that inflationary rate, predicted a 19,500 cost, but we only have a 13,678 at the top, and the bottom is likewise come up a little higher. So we're tighter, and that's reflected over here in these numbers that follow that those, what is that, 8 years from 2011 to 2018, and show us that we've been tightening those numbers. We had a drop and then a rise in the average, which is the blue dot here in the middle. This gray box, the top of that is at the 75th percentile, the bottom at the 25th, and the lines here at the top just to peg the highest and lowest prices or costs in the nation. So it shows that it's not quite as dramatic as it was in '95, but it's still pretty dramatic. There's still pretty big changes, differences in the cost of healthcare from region to region. And of course, one of the first questions that come to mind is, are we getting the best care in those most expensive areas? And the answer, it proves, is no. And this was published in the Journal of American Medical Association in 2003, and lines up states, not exactly the same divisions, reflective, but not exactly right on. But all the 52 states are lined up here and compares the quality ranking from the highest quality up here and the cost to the highest cost up here, and shows a great deal of variation. And it shows a relatively linear connection that equates higher costs with lower quality, and the reverse, the higher quality with lower costs. Now the spread is broad enough. The noise in there is enough that you can't really use this to say, well, the highest cost, or excuse me, the lowest cost state is what is the protocols we should be emulating. But what it does tell me is that it's possible to. It tells me first that cost and quality are not linear, or not directly related. That is, high cost doesn't equate to high quality. And it also shows you it's possible to have a system that's much lower cost and much higher quality. Again, doesn't tell us exactly where to find those protocols. One of the problems here is that we have it's not a deliberately developed system. We have, if we talk about it in terms of the healthcare referral regions or the hospital referral regions, we essentially have 306 natural experiments in healthcare systems, and I think at any system, it's not conscious how it got to where it is. It's just the slow evolution of medical school training to reinforcement in residency to the years in practice, and how we interact with each other, how we peer review each other in hospitals, and what leads one person to do it one way and another in another way. So again, you can't go to any one region and say, we're going to do it exactly the way you do it, and then we'll get much better performance. But it does show that we can learn something from each other, and that it is possible to, if we're deliberate about it, to engineer a system that gets what we want. So I did a quick what if analysis just to answer the question, is it worth doing this? So I took that onion graph and I looked at, separated things by quartile and then the 10th percentile, going by those 2018 expenditures that we saw a moment ago. And then I took those 306 hospital referral areas and weighted each by their population to get a more normalized number, ranked them by the Medicare per capita expenditures, and stratified on the percentile, so I knew which hospital referral region was in the upper 75th, the upper 50th, upper 25th, and the upper 90 or lower 10th percentile. And then made what if we were successful in bringing costs down to this level? What would happen to our total expenditures if we did? So here's what I came up with. At an annual U.S. healthcare expenditure of 4.1 trillion, if we brought all that top quartile down to no worse than the 75th percentile, we would cut $65 billion out of the annual expenditures. If we brought the top half down to no higher than the average, we would cut 173 billion out of the annual expenditures. And if we brought everyone down to the lowest quartile in expense, we cut 304 billion out. And there's an achievable benchmark of care. I don't know how much exposure you've had to that, but the intent of that ABC is to say, well, you can't get to it's unreasonable to think everyone can get to the current best. And because we don't really know we can't say the quality is necessarily the best at the lowest expense area. Let's shoot for a more achievable benchmark at the 10th percentile, and that, of course, would cut about 631 billion out of the annual expenditures. So an interesting analysis. Don't know how far we can go, but at least it does demonstrate that there's some value to pursuing this direction. Now, we've always had, or at least in my professional memory, goes back almost to my entry into the healthcare system, there's always been some kind of a federal program that's tried to bring our costs under control. And this lists some of them, and it's an interesting study to just understand what each did to the system. But that's out of the scope of today's discussion. But now we have the macro, the quality payment program that was launched because of the macro legislation in 2015, and then amended by the 21st Century Cures Act. Those are the major drivers or federal incentive systems to push that policy. And that brings us to a more solid understanding of why I am talking today about cost. And I'd like to, you may, if you've been following my webinars, you've seen some version of these graphs at some point, but I cleaned them up a little bit for today's purposes. On the left, that shows how the MIPS system has changed year over year in the potential adjustment. So we started at ±4, and we're now up to ±9. This is by performance year, so this is actually the third year we're in a ±9 system. But we've never felt that. For the first thing to realize is that by performance year, it's 2 years later that those adjustments affect our Medicare reimbursements. And we know there have been so many special rules. There have been bonuses. There have been top weighted measures, and there's been enough outs that very few people ever hit the deepest penalties that you can get. And as a result, since it's a budget of neutral program, no one's ever exceeded more than 1.8% or give or take a little bit on the incentive upside. And and this is the third year in a row that COVID that Medicare has declared an automatic nationwide exclusion. So if you don't submit, you don't get penalized. So that affects this completely. So we've really not felt this plus or 9% yet. Although now we're at a cruising range, and I expect to stay at plus or minus 9 for the conceivable future. And Medicare has mapped out plans now that take us at least the next decade, unless there's a major change in direction that's going to come through, that we can expect these to continue. Some of the other rules that relate to whether this comes through, we can expect to get a little tighter and a little bit more drastic as the years draw on. And the second factor is this right-hand table or graph that shows they've been balancing quality and cost all these years as well. It started with all quality, added a little cost, and brought it out to this is the first year that they're balanced at 30-30. And of course, because they're constant throughout, I pulled out the promoting interoperability and the practice improvement scores that are also in this table. But you can see how cost has progressed until this year's the first year it's equal at 30-30, and we expect it to continue to sail out unchanged from there. And as this has been going on in MIPS, we know that alternative payment models, they have always worked with both cost and quality. Quality is getting a little bit more stringent as the quality threshold goes up over the next couple of years, and the cost has always been built into the contracts. In the biggest APM, the shared savings program, shared savings being your reward for low cost and quality, so it's always been there. Again, now it's a topic for us, not just because it's hitting MIPS a lot harder now and ramping up over the next few years, but we're also moving into the APM market, helping our APM friends and clients with those as well. So now cost again isn't felt yet at a 30-30 level, again for two reasons. Performance share doesn't pay until 2 years later, so this peak at 30-30 you're not going to feel until your 2024 Medicare reimbursements. And of course, all these previous years, and including the current submission season for 2021 data, very affected by the automatic extraordinary circumstances for COVID. So we're really not being, we can expect cost to hit more and more as we adjust to or emerge from this COVID pandemic. So let me just take a quick breath. I'm going to the next section. Let's see how we're doing. All right, cost is not just money. First, don't confuse cost with price. Price is what we charge. It's what's requested in exchange for something. Cost is what's traded in exchange for it. And I deliberately use the term traded because it's not always money that's traded for something. Cost has more components than just that. Now, it's interesting that price from our perspective, what we charge for our service, becomes cost at the next level, what is paid or what is traded for that service. And likewise, as we think about the cost of providing the care, it's the price that we pay for our office space and our staff and our supplies becomes the cost that we pass on, or the price that we pass on to our clients. So there's that relationship. Now, also, price is highly controlled in healthcare. There's usual and customary is the typical terminology for that, and Medicare, of course, sets what they're going to pay, and all other insurance, commercial insurance, does that as well. There's very little that is changeable based on our selection. and a very small part of the population that is subject to our pricing strategy. So cost is money, and but other things, other tangible costs and intangible costs. The tangible, including things that can be measured, like time, effort, materials, and we usually see those as the factors in most service contracts. Whether it's spelled out, it's oftentimes spelled out directly. Sometimes it's just behind it. And then the intangible costs, hassles, risks, and suffering. And you can think about how these things play out in healthcare, and we'll do that as an exercise in a moment as well. Now, the quality Medicare and the quality payment program uses the terms cost and resource use as synonymous. So if you read their intentions, what their plans, their motivations, their strategic plans, you'll see nearly almost a balanced use of both of these terms as synonymous. So they're not resource use, and I think it's useful to understand this because it puts us in the right mind frame to think of how we're going to reduce our costs and make things easier for our patients. And resource use in the context of healthcare, or the cost of healthcare, is relatively insensitive to the price or the cost per unit service. It's more sensitive to the efficiency and the effectiveness. So the cost per visit for 10 visits gives us one number, but if you can bring the number of visits down to 5 to achieve the same result, you get a much lower cost overall. And so it's really more sensitive to the number type and effectiveness of the encounters than the actual price. And I think acknowledge in this point that chaos and waste are expensive. So too many visits when fewer would do are expensive. Going in the wrong direction, making the wrong choice for treatment or the wrong choice for placement, those can be quite expensive. And again, we'll get more into that in the next section when I drill in on succeeding in the in a value-based care program. And the QPP cost measures total per capita cost, typically shared, and the shared savings program, which reflects budgeted costs or expected costs. Medicare spending per beneficiary, which is the average cost of hospitalization, and then episode cost measures that most specialists will be judged on. So kind of as an example, let's think about hip pain that brings a patient to attention and ultimately leads to a hip replacement. Thinking about it in resources and costs. So the resources include, there's a primary care visit in the E&M code as a charge for that hip pain, a set of diagnostic tests, and then some treatment. And you can think in terms of what it's going to cost for each step of that treatment. And as it works or doesn't work, you keep adjusting the treatment until you say, well, I'm not going to be able to succeed here. We need a referral. So there's a special referral. There's diagnostic tests that may or may not duplicate what's done before. So there can be some waste there. And then progressive specialty treatment, which could again be duplicative and therefore wasteful, or it can just take up where the primary care left off. Then there's hospitalization for hip replacement, some kind of recovery and rehab, and then ultimately return to work and functionality. And some of the costs, as we look at that, of course, the cost and payment for all the visits, for the tests, for the treatment, for functional assessment, and for the patient, they're going to be having lost time from work. And lost time from functional effectiveness at home, and it figures highly into their perception of cost, how long they have to be out of function. So we can, as we think about this flow, we can start thinking about how we can take cost out of each of those, and we'll talk talk about that again in more detail in a couple weeks. So just to summarize, resource use is expressed in terms of money in QPP and value-based programs. And think we don't tend to look at things in those value-based programs unless they can be converted to a monetary basis. And I like to call that the tyranny of the measurable. We see it a lot in quality, that we measure those those quality aspects that are easily measurable, and then we can't measure those other things. And in cost, it's similar. Now they're addressed in other ways, like the hassle factor. How long do they have to wait? How easy it is to get an appointment? All those other things that can pile up on the cost side for your patients. That's reflected in the survey measures. Of course, we're not all subject to the survey measures, but it's there. Patient centeredness, those things that make it easier for a patient, or more likely for a patient to seek care and help. And seek it from you. That's reflected in improvement, not only in the survey measures as well, but also in the improvement activities. If you look at the improvement activities, the glue that holds most of them together is an intent to become more patient-centered. And of course, overall, it's the quality of life work is what it comes down to for one of the most important things for patients. And now we start getting into the overlap. We can sometimes move things in that value equation to the top or bottom of the equation. And when you start thinking of joy and profit in practice, how can we deliver a practice in which we enjoy working and delivers a high value to a patient? Job satisfaction is a big part of it. The profit loss is that monetary part, and as you're working on your and the bigger the business, typically the more carefully they're tracking that. Profit margin is of course extremely important. Panel size is very important, particularly as we're moved from a system that's optimally performs for the provider with a higher volume of services to a system where taking care of more patients is the volume driver. So that panel size becomes more important as we progress through this process. Availability becomes important, and how we do that without overstraining our own resources, our own practice enjoyment, and that of our staff. And how do we make the system more efficient and effective? And again, we'll dig into that in a month's time with a third in this series. So let's quickly, let me just take a pause and talk about the various dimensions of cost. So again, we talked about cost being monetary. And we talked, and you've heard about some of those non-monetary costs, which I divide in, or can be divided into tangible and intangible. Tangible being time, effort, and materials. You see this in many of the service contracts we get into. It's either very clear, the language of the contract, or it's buried in there in some form or other. But those are the most important material aspects that that lead to selection of price and determination of cost. The intangibles are a little harder, but even those there are conversion techniques to get those to the dollar. The hassles, the risks, the suffering that are harder to measure than those other tangible costs. And the perspectives we work from, the important perspectives, of course, is the patient. How much does it cost the patient? And they're very conscious of the out-of-pocket costs, and they're certainly conscious of the health insurance costs. But it's interesting that in my experience, I don't see people try to maximize their insurance benefit, even though that in the long run can drive up the cost of healthcare. And creates kind of a perverse incentive system that may be partly responsible for why our healthcare expenses go up much faster than the overall cost of living. And of course, the health insurance company, which has a different perspective than the patient, it is more monetary, not so much. They don't suffer from the wait, they don't suffer from the delays, they don't, they're not in pain if there's a delay in being seen, and they're almost insensitive to cost, simply because as the cost of healthcare increases, they can increase the subscription price to their patients or to the companies that are enlisting them, and they take typically it's about 11 cents of every dollar for administration of this system. So they can be relatively insensitive to price. Now, of course, they have to be competitive, so it comes out in how they have to be competitive on two levels. They have to be competitive with their patients and their plans that they're marketing, sometimes directly to patients and sometimes through the employer. They also have to be competitive in building a panel of providers, so pay well enough that they can get the providers they want. And the employer, very similar to the insurance company and the patient, but they had that perspective of work efficiency, and a concept that's referred to as presenteeism. That is, employees are there, and are they well enough, both physically and mentally, to be contributing to the business. So that's very important. So they're a little bit an important perspective, and again, we'll go into that in a little more detail in the future sessions. The provider has their own perspectives on the cost. Sees the things that they affect, a little bit of a glimpse into what happens downstream as you refer patients elsewhere for tests or treatment. And of course, legislators and the regulatory environment also interested in the patient and need to compete for votes to some extent. Also concerned about the health of the region, the financial health of the region, the gross domestic product and things like that. So again, being aware of these as you're trying to formulate your plans is very helpful. And so I took a walk through this in a grid which has each of these entities in the as rows, and the classes and specific expenses in the columns, and thinking a patient really goes across all of those. The payer kind of eliminates the intangible. The insurance company payer, it eliminates the intangibles. The employer really focuses on the monetary and a lot of the intangible, which represents the presenteeism. And the provider really focused on the time, effort, and materials, not so much the intangibles, except as it comes to the special perspectives that contribute to a enjoyable practice. And the legislatures, again, the risks and suffering are high on their list in order to please their constituents, and monetary for that gross domestic product is a big factor. So let's talk about these special terms of cost effectiveness, profit effectiveness, and value. And I present my 2x2 grids for these. Cost effectiveness. So we put cost on the horizontal axis, effectiveness on the vertical axis. Cost effectiveness is a ratio of cost of effectiveness divided by cost. So as you increase cost, it lowers the overall cost effectiveness. As you increase effectiveness, it raises that. So you get this system where it's relatively easy to choose when one thing falls into the green box and another falls in the red. This green is far more cost effective. So in yellow, it's really fairly neutral. Two choices which fall into the same box. Again, now you have to start looking at the relative area. But again, we want to provide things, and people want to buy things that are highly effective for a lower cost. And effectiveness can be expressed in terms of cure or control, restoring of function, avoiding complications, survival rates, avoidance of pain and suffering, and the costs, of course, all those things we have talked about before, the monetary and the non-monetary factors. Profit effectiveness. I stumbled upon this as I was thinking about cost effectiveness and whether we as physicians or providers deliver cost effective care. And I realized that we're more driven by profit effective care, that something is more likely to be delivered if it's profitable and more likely to be delivered if it's effective. And they become a multiplier, not a division. So both of those being high increases the likelihood of being delivered. Both of those being low decreases the likelihood. And again, the more typical expression of that is profit margin, which doesn't take the effectiveness into account very well, but it is that side of the profit. And again, similar measures of effectiveness, really pretty much the same. And profit is the revenue related to the service, the cost of providing the service, which is expressed in fixed costs, variable costs, and non-monetary. And this is where we'll be spending our time in the third session about a month from now, how we optimize that practice for profit or margin, as we say. And of course, we want to remember profit is not a four-letter word, and in the words of some of our faith-based colleagues, no margin or no money, no mission. So we've got to have that to keep going. And of course, the value equation being quality divided by cost. And again, that is a division. So the higher the quality, the higher the value, and the lower the cost, the higher the value. So those work in cross purposes there. So we're searching, and quality tends to be to accumulate those cost effective. So take that earlier one, lump them all under quality. We want those things that we know to be cost effective to be delivered to our patients, and they go into that the quality side of it. And then the cost of delivering that total package, it goes into the cost side of things. And again, so the value, the things that affect that on the quality side, we want to maximize the quality adjusted life years. This is if you're going to get deeply into quality, you want to understand that roll up. And people want their years of life to be of the best possible quality. So they will tend to trade lower quality years, a large number of low quality years for a smaller number of high quality years. And a similar kind of a different perspective on that same theme, years of potential life lost is another kind of way to roll a lot of different measures up into one. Overall, so what we want to picture from that as we think about it in structuring our practices, we want to provide all indicated interventions and avoid those that are contraindicated. So it's a misadventure, it's wasteful, it's a higher cost to provide something that someone's allergic to, or something that if you look more carefully, you know isn't likely to be effective. We want to choose those things that we expect to be higher effectiveness right out of the box. and of course the same list of things that we've been talking about on the cost side. So summary considerations of all that: we want to provide high value healthcare, and the consumers for affordable healthcare put it well: high quality, affordable healthcare for all. The triple aims is similar with a few more words, still quite eloquent. And we want to be effective stewards of the health and resources of our patients, the patients who are trusting us with their care. Providing that high quality care, mindful of the cost at all times. And that lowest statement there, picture that you are part, whether you intend to be or not, you are part of a healthcare system. It might be planned, it usually isn't. It's more accidental, it's more evolutionary in your region, that people enter in one place, they progress through. We want that experience of healthcare to be effective and efficient. We want it to be experienced by the patient as a rational, disciplined, and purposeful totality. And if you think about the care in those terms, you'll start to come to the realization of what has to be improved overall to improve the value of that care. And to maintain and improve practice vitality, we've got to have a system that our best and our brightest are going to go into. So it's got to be rewarding personally, professionally, and financially. And we can't keep treating profit as a four-letter word. Guess enough said on that. And then to earn incentives in the value-based incentive programs. Cost has a composite payment for an episode of care. It has to be measurable. To be measured, it has to be measurable. So that gives us that tyranny of the measurable. It really is the true cost is the sum of payment from all payers. That's typically the insurance company, whether it's the insurance company or it's a self-insured employer, plus out-of-pocket expenses. So there can be a challenge, and I think currently in the quality payment program, it typically excludes some of the measures exclude the out-of-pocket side, and some of them don't. And I'll hopefully get a little bit more of that into that second presentation in 2 weeks. And we'll get into the TPCC and the MSPB in that session as well. And specialists, you're going to be judged on cost, but mostly on the episode measures, and we'll talk about that then as well. As you want to read more about this and understand more about costs, I think I've introduced some data from these organizations, the Organization of Economic Developed Countries for Economic Cooperation and Development here. The Dartmouth Atlas, rich source of data about variation in cost. And then the Commonwealth Fund is behind a lot of the data I presented. Health Affairs, great journal that talks about the cost effectiveness and the cost matters very efficiently and effectively. My favorite journal. So join us in a couple weeks for discussion of the specifics about the QPP, alternate payment models, and MIPS, and then 2 weeks after that for the efficiency and effectiveness, the costs relating to your practice and profit. So I can take questions. I have a couple minutes left, and go. We can walk through some of the pre-submitted questions as well. So do that as we wait for any of your current questions to be communicated. Dale asks, how is the Medicare spending per beneficiary used? And I'll use that as a teaser for come in 2 weeks. It's a and I'll talk about that in a lot more detail. And I think a lot of these pre-submitted questions, I'm going to have that same answer that we'll give it the time it deserves 2 weeks from now. Laura asks, how can specialty providers with limited scope practices providing wound care participate in value-based programs? Can we benefit from the fact that we save costs for our patients by keeping them out of the hospital? And the answer there is absolutely. And again, for the details, we'll cover that in 2 weeks. But think of that, the healthcare system as just that, a system. And you need to map out your spot, and you need to show your referral sources how it is that you save money in the greater scheme of things by consuming some of that money yourself, by having your practice supported. And then Alicia asks, are you aware of Commonwealth Fund's social determinants of health return on investment calculator? It can help organizations project costs to coordinate care, implement programs for controlling costs. Alicia, thank you. That's a great question, and you introduced me to the SDOH calculator, and I had a chance to look it over, and I'll give it a partial recommendation, only because I think it's a great tool, and it might be worth it just to understand how to use it, to be introduced to how expenditures to overcome social determinants of health actually may help the healthcare cost bottom line. So go have a look at it yourself. I found it just by Googling Commonwealth Funds SDOH ROI, and it'll take a little time to walk through it and understand it. And if you actually start, I think, again, understanding all the fields and all the requests is your first challenge and your first value. Actually using it, I can't attest to how well it works. It appears to use standard measurements, observed measurements to project how certain expenditures will act. It probably works well in the middle ranges. I don't know how it works at the extremes, which is where these things commonly fall apart. But again, looks like a great conceptual framework. Jessica asks, what suggestions do you have for how to control your total per capita cost attribution for mid-level providers who work in specialty practices? Again, we'll bring that up in more detail in 2 weeks. Ophthalmology practices, do all cost measures apply? Again, this very applicable to that next session. Danielle, if we are specialists, are my PA NNP still included in the attribution for TPCC since they don't have a specialist? I'll just quickly give you, again, this will come up in 2 weeks, but Medicare is taking increasing pains to divide services between actual primary care practices and specialty practices. Whether they're effective or not, fully effective, that's still in question. But we'll talk about that more next time. And how do you prepare for a pharmaceutical utilization and value-based cost control? Well, you start, John, by being aware of the costs and making sure you're choosing more cost-effective prescriptions. But again, we'll hit this in more detail next time. So, I think we're out of time now. It's top of the hour. Thank you very much for coming. I've enjoyed it. I hope I didn't put all of you to sleep. And I'll look forward to seeing you again in 2 weeks for the deep dive into the acute quality payment program cost categories, and then 2 more weeks for practice efficiency and profits. So thank you very much.
All right, thank you so much, Dr. Mingle, and thank you everyone for joining us. Keep an eye out in your email for the slides and recording later this week. And we're excited to have you join us in 2 weeks. If you have friends, colleagues who you think need a refresher or want to dive into what it looks like to succeed in the cost components of MIPS and value-based care, definitely please share the upcoming sessions with them. We'd love to have them. So thank you all and have a wonderful day.